Hey everyone, welcome to another deep dive. You guys know those orthopedic exams like FRCS are no joke. Anatomy is a huge part of it. So to make it a bit easier, we're going through some high-yield anatomy points today. And get this, we're using the Ortho Made Simple notes from mokyingren.sg. These were put together by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital over in Singapore, and he actually crushed his FRCS back in 2022. So yeah, we're in good hands today. Let's get started with the upper limb, the rotator interval. It's always on those exams. Why is that?
It is a tricky one. The rotator interval is shaped like a triangle. It's right there at the top of your shoulder. You've got the supraspinatus and subscapularis tendons forming two of the sides, and the coracoid process makes up the base.
So it's not just some random empty space then. What makes it so important for us to know?
Think of it like a doorway, a very important doorway. It controls the movement of a few key structures: the biceps tendon, the coracohumeral ligament, and the superior glenohumeral ligament. Those are all really important for shoulder stability.
So if things get too crowded in that doorway,
They get impingement.
and if it's too loose,
You've got instability. Surgeons need to know this area inside and out.
it's like a traffic control point for the shoulder. Makes sense why it's such a popular topic on exams. Now, zooming out a little bit, the shoulder itself, it's not just one big empty space, is it?
Oh, definitely not. There are actually distinct spaces within the shoulder, each with their own unique contents. And these are really important surgically. For example, you've got the triangular space. It houses the circumflex scapular artery. That's a vessel we need to be careful of during shoulder surgery.
It's like a hidden road map of all those critical structures. Okay, so we've talked about the rotator interval and these spaces. What about bony landmarks? The coracoid process, that one always seems to be a big deal.
The coracoid process, it's like the grand central station of the shoulder. Seriously.
Yeah.
This bony prominence has 7 different structures attached to it.
7.
You've got 3 muscles that originate there: the pec minor, the short head of the biceps, and the coracobrachialis.
Wow, that's a lot of muscle attachments for one little process.
And we're not even done yet. Don't forget about the ligaments.
Oh, right. There are a few, aren't there?
4 to be exact. The coracoacromial ligament, the coracoclavicular ligament, the coracohumeral ligament, and the transverse scapular ligament, with all those important structures attached to it. The coracoid process is really crucial for shoulder stability and function.
I can see why it's a favorite on exams. Okay, so we've covered some bony landmarks. What about the nerves? The axillary nerve always seems to cause trouble.
The axillary nerve is really important for proper shoulder function, and its pathway is something you need to know. It branches from the posterior cord of the brachial plexus, goes behind the axillary artery, then it kind of sneaks through this space called the quadrangular space, before finally reaching its destination, the deltoid muscle.
So if we see a patient with deltoid weakness, damage to the axillary nerve should be on our radar.
Absolutely. Understanding the course of the axillary nerve is really important for diagnosing and managing nerve injuries around the shoulder.
Okay, so we've talked about the upper limb a bit. Now what about the lower limb? There's a lot going on down there.
Oh yeah, the lumbosacral plexus is a big one. It innervates the entire lower limb.
The lumbosacral plexus, it's like a tangled web of nerves. How do we even begin to make sense of it all?
The key is to break it down systematically. It's formed by the ventral rami of spinal nerves L1 to S4.
Okay, so we're talking 5 spinal levels.
Right. And what's really important for the exam is knowing which specific roots contribute to each major nerve.
So for example,
The femoral nerve, it arises from L2, L3, and L4.
wow, okay. And what about the big one, the sciatic nerve?
That one comes from L4, L5, S1, S2, and S3.
Wow, that's a lot of roots.
It is. It's the largest nerve in the body. Knowing those nerve roots is essential for pinpointing where a spinal injury might be based on the patient's neurological deficits.
That makes a lot of sense.
Mm-hmm.
Okay, so we've covered some key nerves in both the upper and lower limbs. What about blood supply? That's another one that always seems to trip me up.
Blood supply is definitely important.
Right.
Let's start with the femoral head. It's really interesting how it changes as we grow.
Wait, the blood supply to the femoral head actually changes over time. I don't think I knew that.
It does. There's a classic study by Truetta that you should definitely know for the exams. It shows that from birth to adulthood, the main blood supply shifts from the metaphyseal arteries to the epiphyseal arteries, and there's also some contribution from the artery of the ligamentum teres.
Okay, so why is this shift in blood supply so important to understand?
Well, think about what happens if the blood supply to the femoral head gets disrupted. You could end up with a vascular necrosis. That's a serious condition where the bone tissue starts to die because it's not getting enough blood flow. Understanding how the blood supply changes as we develop helps us to properly diagnose and manage conditions like that.
That makes perfect sense. Okay, so we've got the blood supply to the femoral head. What other key areas should we be focusing on for these exams?
Well, the femoral triangle is another classic anatomical region that you'll need to know really well.
The femoral triangle.
Yeah.
I always struggle to remember the order of the structures in there. Is there an easy way to remember it?
There's a mnemonic that I like to use. Navel.
Navel.
Yeah. It stands for nerve, artery, vein, empty space, and lymphatics. That's the order of the structures from lateral to medial within the femoral triangle.
Navel. I'm definitely going to remember that. So we've got the femoral nerve, artery, and vein running through there. What about that empty space? Is it really empty?
Not completely, but it's relatively free of major structures. That space is important because it allows for some movement and expansion of the vessels within the triangle.
Okay, that makes sense. The femoral triangle is definitely one of those areas we need to have a good grasp on.
Absolutely. It's a common site for procedures like femoral artery catheterization and nerve blocks. So knowing the anatomy really well is crucial.
Great point. So we've covered a lot already. The rotator interval shoulder spaces, the coracoid process, axillary nerve, lumbosacral plexus blood supply to the femoral head, and the femoral triangle.
Oh.
Yeah, that's some serious high-yield stuff. And remember, all of this is based on those OrthoMed Simple Notes over at mokyingren.sg. They're an amazing resource for exam prep.
They really are, and we've got a lot more to cover.
Let's take a quick breather and then we'll jump right back into it. Okay, so we were just talking about the femoral triangle. Let's move down the leg a bit. What about the popliteal fossa? That always seems like a tricky area.
It can be. The popliteal fossa, it's this diamond-shaped space behind the knee. It's bordered by the muscles of the thigh and the calf.
Okay, so I've got our diamond shape. What's in it?
A lot of important structures. The popliteal artery is the deepest one. It runs right down the middle.
Okay, artery down the middle. Then what?
Superficial to the artery is the popliteal vein. And right above that, you have the popliteal nerve.
So artery, vein, then nerve.
Yeah.
From deep to superficial.
Exactly. You've also got the small saphenous vein draining into the popliteal vein.
Right, and don't forget the lymph nodes.
Oh, yeah. Those are tucked away in the fat within the fossa.
So many structures in one little space. It's no wonder it's important to understand the anatomy there.
Yeah.
Especially for procedures.
Exactly. Whether you're doing a knee arthroscopy or a popliteal artery bypass, or even just assessing a patient with a posterior knee injury, knowing the anatomy of the popliteal fossa is crucial.
Speaking of the knee, let's talk about the layers of the knee joint.
Mhm.
I remember learning about it in med school, but it always felt a bit overwhelming. Is there an easy way to think about it?
There is. A good way to visualize the layers of the knee, both medially and laterally, is to imagine a three-layered cake.
Okay, I like where this is going. Instead of frosting, we've got...
Ligaments, tendons, and nerves.
Okay, I'm with you. So what are the ingredients in each layer?
Let's start with the lateral side. The first layer, the most superficial one, it's like the top of the cake. That layer has the iliotibial band and the biceps femoris tendon.
What about the common peroneal nerve? That one seems to be pretty vulnerable. Where does it fit in?
Ah, yes. The common peroneal nerve, that one's tucked away between the first and second layers, like a delicate layer of filling. It can get injured pretty easily, especially with direct blows to the lateral knee.
Okay, so we've got our frosting and our filling. What's in the second layer of the cake?
The second layer has the patellar retinaculum.
Which helps to keep the patella in place.
Exactly. And you've also got the lateral patellofemoral ligament. It provides stability to the outer side of the kneecap.
Okay, and then the third layer. That's the deepest one.
Right. The third layer is like the base of our cake. And it's actually divided into two parts, a superficial part and a deep part.
Two parts. Okay, what's in the superficial part?
The superficial part has the lateral collateral ligament. It keeps the knee from buckling outward. Then there's the anterolateral ligament. It helps with rotational stability. And we've got the lateral geniculate artery running between the LCL and the AL. It supplies blood to the structures in that area.
So many structures packed in there. What about the deep part of the third layer?
The deep part has the popliteofibular ligament, which reinforces the back of the knee joint. The popliteus tendon, which helps unlock the knee from extension. The capsule, which surrounds the entire joint. And the arcuate ligament, which gives extra support to the posterolateral corner.
Okay, that was a lot. What about the medial side of the knee? Is it the same?
It's similar in that it also has three layers, but the specific structures are different.
Okay, so let's break it down. What's in the first layer on the medial side?
That one's easy. It's just the sartorius muscle.
Just the sartorius. Simple enough. What's hiding between the first and second layers then?
That's where you'll find the pons anserinus.
The pons anserinus. What is that exactly?
It's the combined insertion point for three different muscles. The sartorius, the gracilis, and the semitendinosus. They all come together to form this goosefoot structure.
Ah, okay. The pons anserinus. I always remember that name because it sounds so unique. What about the second layer?
The second layer on the medial side contains the superficial medial collateral ligament.
So that's the one that prevents the knee from buckling inward.
Exactly. You've also got the medial patellofemoral ligament. It helps stabilize the inner side of the kneecap. And then there's the posterior oblique ligament. It provides extra support to the back of the knee.
And that brings us to the final layer on the medial side. What's in there?
In the deepest layer, you have the deep medial collateral ligament. It works with the superficial MCL to give the knee stability. And of course, you've got the capsule. It surrounds the whole knee joint. And finally, the coronary ligaments. They connect the menisci to the tibia.
Wow, that was a whirlwind tour of the knee layers. It's amazing how many different structures are in there working together to keep the knee stable. But it makes a lot more sense now thinking of it like a cake. And remember, this is just a taste of what's covered in Dr. Mok's Ortho Made Simple notes.
Right, we've just scratched the surface of the knee joint.
Well, before we dive too deep into the knee, let's step back and look at some other key areas of the lower limb. What about the hip? We talked about the femoral triangle and blood supply to the femoral head. But what else should we know for the exams?
The sciatic foramina are definitely worth reviewing. They're like gateways where nerves and blood vessels exit the pelvis and enter the gluteal region.
Right. There's the greater sciatic foramen and the lesser sciatic foramen. What are the key structures that pass through each of those?
The greater sciatic foramen is the bigger of the two, and it's divided by the piriformis muscle.
The piriformis muscle. Oh, yeah, I remember that one.
So structures that pass above the piriformis include the superior gluteal nerve and artery. They supply the gluteus medius and minimus muscles.
What about below the piriformis?
Below the piriformis, you have the sciatic nerve itself, the inferior gluteal nerve and artery, the nerve to quadratus femoris, the nerve to obturator internus, and the pudendal nerve with the internal pudendal artery.
Wow, that's a lot of structures going through one foramen.
It is. And knowing what goes through each foramen and whether it goes above or below the piriformis is really important for understanding different conditions that can affect the gluteal region, like piriformis syndrome.
Makes sense. What about the lesser sciatic foramen?
The lesser sciatic foramen is mainly an exit point for the tendon of the obturator internus muscle, the nerve to obturator internus, and the pudendal nerve with the internal pudendal artery.
So the greater sciatic foramen is like a major highway, and the lesser one is more like a local road.
Okay. What about the blood supply to the femoral head? We touched on that earlier, but is there anything else we should know?
We talked about how the dominant blood supply shifts from metaphyseal to epiphyseal arteries over time. But it's important to know the specific stages and ages when those transitions happen.
Right, the timeline. Can you walk us through that again?
Absolutely. From birth to around 3 years old, the blood supply comes mainly from the metaphyseal artery and the lateral epiphyseal artery.
So those are the main players early on. Then what? From around 4 to 8 years old, the lateral epiphyseal artery takes over as the primary supplier, and the metaphyseal vessels start to recede.
It's like a changing of the guard. What happens between 8 years old and puberty then?
Between 8 and puberty, the lateral epiphyseal artery shares the responsibility with the artery of the ligamentum teres.
And finally, from puberty to adulthood.
From puberty on, the blood supply comes from 3 sources: the lateral epiphyseal artery, the artery of the ligamentum teres, and the metaphyseal artery. It makes a bit of a comeback.
Quite a journey for those blood vessels. So why is it so important to understand this timeline?
Because it helps us to understand what could happen if there's an injury or condition that affects the blood supply to the femoral head at different ages. For example, a fracture of the femoral neck in a young child could damage those metaphyseal vessels. That would lead to a higher risk of a vascular necrosis.
I see. So knowing the different ages and stages of blood supply development can really help us make the right clinical decisions. And don't forget, all of this information and much more is covered in the Ortho Made Simple notes by Dr. Mok Ying Ren.
Right, you can find those notes on his website, mokyingren.sg.
They're an incredible resource for anyone getting ready for those orthopedic exams.
Yeah.
We've covered a lot of ground today. We talked about the popliteal fossa, the layers of the knee, the sciatic foramina, and the blood supply to the femoral head. That's a lot of anatomy.
It is. But remember, every bit of knowledge you gain brings you one step closer to acing those exams. Keep up the hard work.
We'll be right back with you after a quick break. Okay, we're back. Let's keep going with our anatomy review from the Ortho Made Simple notes over at mokyingren.sg. We were just talking about the hip. Now, how about we shift gears and head down to the ankle?
The ankle joint. It's all about stability. It needs to be strong enough to support our body weight, but also flexible enough to allow for a good range of motion. That's where the ligaments come in.
Okay, ligaments. I know there are a bunch of them around the ankle. How can we keep them all straight?
It helps to think about it in terms of medial and lateral stability. On the lateral side, we've got three main ligaments that prevent too much inversion, or in other words, inward rolling of the ankle. The anterior telifibular ligament, the posterior telifibular ligament, and the calcaneofibular ligament.
Those are the ones that we see injured most often, right?
You got it. The anterior telifibular ligament, that's the one that gets injured most commonly in the ankle, usually with an inversion sprain.
Makes sense. Now on the medial side.
On the medial side, we have the deltoid ligament. It's actually a group of 6 ligaments that work together to prevent excessive eversion or outward rolling of the ankle.
So the deltoid ligament, it's like the superhero on the medial side.
It's much stronger than those individual lateral ligaments. That's why medial ankle sprains are less common.
Okay, that makes sense.
Yeah.
Are there any other important bony landmarks around the ankle that we need to know?
One that comes up a lot is the sustentaculum palli. It's a bony prominence on the calcaneus. That's your heel bone. It plays a big role in keeping the ankle stable.
The sustentaculum tali, what makes it so important?
Think of it like a shelf that supports the talus. That's one of the bones that makes up the ankle joint. The sustentaculum tali has 3 important ligaments attached to it. The tibiocalcaneal ligament, the talocalcaneal ligament, and the spring ligament.
Ah, the spring ligament. Why is it called that again?
It's called the spring ligament because it's got this springy, elastic quality to it. It helps support the arch of the foot.
So the sustentaculum tali and those ligaments, they're both important for ankle and for stability.
Exactly. They work together to keep things functioning properly.
Okay, so we've got the ligaments and some key bony landmarks. Anything else we should cover for the ankle?
I think we've got the ankle covered for now. Let's move on to the hand. It's got such intricate anatomy and it often comes up on exams. Let's talk about the muscles that control finger movements.
The hand. It's pretty important for surgeons, right? So the muscles that control the fingers, why are those so important?
They're crucial for hand function and dexterity. The key muscles to know are the interosseous muscles and the lumbrical muscles.
Okay, interosseous muscles and lumbricals. What do those do exactly?
The interosseous muscles, they're located between the metacarpal bones.
Okay, and there are 2 types, right?
Yes, you have the palmar interosseous muscles and the dorsal interosseous muscles.
I always get those mixed up. Is there an easy way to remember which is which?
Absolutely. The palmar interosseous muscles adduct the fingers, so they bring the fingers towards the middle finger. Think PA palmar adduct.
Key aid. Got it. So if I'm moving my index finger towards my middle finger, I'm using my palmar interosseous muscles. What about the dorsal interosseous muscles?
They abduct the fingers, so they spread the fingers away from the middle finger. Think DAB dorsal abduct.
PA for abduction, DAB for abduction. It's a good way to remember. Now what about the lumbricals?
The lumbrical muscles are interesting. They actually originate from tendons and insert onto tendons.
Oh, that's different.
They help us to flex the metacarpophalangeal joints, so those are your knuckles, and they extend the interphalangeal joints, the joints within the fingers.
So they help us make a fist, but also straighten our fingers.
Exactly. They're key for fine motor control and being able to grasp objects.
The hand is pretty amazing.
It is. And speaking of amazing, we can't forget about the blood supply to the hand.
Right. The blood supply. All those muscles and tendons need oxygen. How does the hand get its blood supply?
The hand gets its blood supply mainly from 2 arteries, the radial artery and the ulnar artery.
Okay, so how do those 2 arteries work?
The ulnar artery is the main supplier. It gives about 80% of the blood to the hand. It forms the superficial palmar arch, which supplies the fingers, and the deep palmar arch, which supplies the muscles of the hand.
And the radial artery.
It chips in about 20% and also helps form the deep palmar arch.
It's a team effort.
Exactly. And it's really important to know the anatomy of these arteries and their branches, especially for dealing with hand injuries or doing procedures like carpal tunnel release.
So we've covered a lot of ground today, from the upper limb all the way down to the hand. And remember, it's all thanks to those OrthoMade Simple notes over at mokyingren.sg.
These notes are a game changer for anyone getting ready for those orthopedic exams.
Don't forget, these notes were put together by Dr. Mok Ying Ren. He's a sports surgeon who aced his FRCS in 2022. They're a great resource. You can find them on his website, mokyingren.sg.
Definitely check them out.
All right, everyone. Keep studying hard. Remember, every bit of effort you put in gets you closer to acing those exams. Good luck.
Best of luck.